8 minutes past 12, so we're going to start. Thank you so very much for the audience on the Zoom. I know that we have around 27, 28 people on the Zoom, and thank you everyone attended in person. I have a pleasure of introducing Dr. James Hu is as our today's ground speaker. He is the director of Sarcoma program at University of Southern California, and considered as one of the renowned nation's experts in the field of sarcoma. He has more than 25 years experience in the clinical oncology, and he managed to kind of link USC oncology and sarcoma centers with many national and international societies, and brought many clinical trials to USC in this field. In addition to his clinical excellence in the field of oncology and sarcoma, he is a great leader who actually advocates for a physician leadership. He believes that not only knowledge and skill needed to successfully navigate the rapidly changing healthcare environment, but also the motivation and understanding of oneself to successfully lead the change. Dr. Hu has extensive formal training in the leadership, including his training at the operational and strategic level, as a graduate of the Command and General Staff College and in the United States Army War College, where he obtained his master's in strategic studies. As a former war commander of a combat support hospital with over 800 personnel, Dr. Hu has gained years of experience in leadership firsthand. His passion and interest in the leadership field has resulted in his recent completion of a doctoral degree in organizational charge and leadership with dissertation entitled The Role of Physician Leadership in Addressing Physician Burnout. He didn't stop there. He decided to share his wisdom and experiences with physicians who are interested in the leadership role. He embarked on a difficult journey to set up and plan the first and the unique physician leadership program at USC. Physician leadership program at USC is a unique program with the aim of applying leadership theories into the practice to serve as a model for a change. I have been fortunate enough to attend the first cohort of this program and learn from Dr. Hu during the last year. And I can confess wholeheartedly that attending this course has been one of the best experiences I had during my academic training. Without any further ado, I'm going to leave the podium to Dr. Hu to hear about his talk, Addressing Physician Burnout, is a relationship with leadership behaviors.
Thank you, Nassim. Can you all hear me up there? Okay, fantastic, so I don't have to yell. Thanks, Nassim. One of our star pupils in the class, for sure. Well, thank you all for having me, Dr. Johnson and Department of Radiology. I appreciate the chance to talk. But I also want to thank the faculty. I think I'm an oncologist, and we all know what kind of challenges you guys are having right now. And I just want to let you know that we appreciate it, and we appreciate you. Without you, we can't do the stuff that we do, or we try to do in oncology. So thank you very much. That was a nice introduction, Nassim. I just want to say this. I'm one of you. I'm on the ground. I am one of the frontline physicians. And when I started doing all of these leadership courses, including the doctorate, I was a frontline physician. So this is my viewpoint. My viewpoint is from the front line. So again, thank you all, and loads of gratitude for what you do. Okay, so the topic today is addressing burnout. Is there a relationship with leadership behaviors? And so oftentimes when we hear about leadership, we always hear about leadership and performance, right? But we never hear about leadership and wellness, right? In our patient population, or in our physician population, or any population that's being led. So that's why I embarked on this dissertation topic, which took me 230 pages to write. Basically, I looked at this institution and found some interesting findings.
Recording in progress.
But before we talk about leadership, let's talk about burnout. What is burnout? So as you can see from this picture of this poor faculty member, resident or fellow, you can see that he's really tired and maybe disengaged, right? So you can see that he's sitting there, he looks emotionally exhausted, okay? He looks like he's doing something that's not very meaningful, and he's probably feeling like he's not really accomplishing a whole lot by doing this task that he's doing. And if I tap him on the shoulder, he might just turn around and start yelling at me, right? So these are the manifestations of burnout. And so Maslach in 1990s basically went over these three categories of burnout, and she's basically written an instrument to measure burnout that is as validated and reliable. So this was part of my dissertation survey, was a Maslach burnout inventory. And they conform to three categories: emotional exhaustion, depersonalization, and lack of accomplishment. So I just put this up here. Here are the items. It's basically a three-category itemization of this instrument. And there's 9 items for emotional exhaustion, 5 items for depersonalization. And I didn't put lack of accomplishment up there, but there's 8 items for that. And again, this is a reliable and validated measure of burnout. And you can see some of the questions. I'll just let that. I'll let you peruse the slides later. I won't get into that too much. Okay. So some of the distinguishing features of burnout. What burnout is not, it is not job dissatisfaction, because job dissatisfaction is typically temporary. So if one week I'm here seeing clinic and my APP is there, everything's great, we're happy. And then she goes on leave or goes on vacation the next week, and then I'm really unhappy, right? I'm dissatisfied. So it's a temporary situation, job dissatisfaction. Now, depression, it's also not depression. What it is, depression basically is a dysphoric mood that affects all phases of your life, not just work-related stuff. So the home, socially, and also work. So it's not just work-related problems. But what it is it's a chronic condition in which you're just continuously exposed at work to stressors, where you start developing dysphoric symptoms, those 3 categories, that develop in response to work-related problems and manifest themselves as emotional exhaustion, depersonalization, low personal accomplishment. So that's the distinction between burnout and those other entities. I don't know if there's any psychologists here or psychiatrists here, but basically it hasn't really entered the DSM lexicon. Right? So it's something that's not a psychological diagnosis. But this is really the meaning of all this. What are the consequences of burnout? And so I presented this once to the business folks, and I wanted to show them these are the consequences. And this is a study that was published by Han et al. In 2019 in the Annals of Internal Medicine. And he basically tried to calculate the financial impact of burnout. And so what he did was he looked at dissatisfaction and engagement. And he estimated that for those folks that aren't involved or not engaged with what's going on, that costs about $7,600 per year per physician. And then they looked at turnover. Turnover is something that we're facing big time here, right? Or resignations, right? And so just to let you know, across the board, we're at 12% resignation rate at this institution, when the baseline rate is 6%, okay? And if you, and generally the ratio between burnout and resignation is somewhere around 6 to 1. So for example, we just did a score survey the other day with our division, and we looked at the burnout rate at this institution. It was something like 60, 65%. So it kind of matches the 10 to 12% that we're seeing. At Cleveland Clinics, which is an academic medical center, not unlike ours, their burnout rate is 35%, academic institution, 35%, and their turnover rate is 6%. So you can see it's about a 6-to-1 ratio. Well, what's the estimated cost? Now, these are just direct costs, not even indirect costs, right? So this is just the cost of replacing, let's say I leave tomorrow, replacing me and also replacing all the revenue I generate. So basically that would cost about $56 million, but not even per year, so for all the physicians at USC, right? So if you have 10%, you have 1,500 physicians here at USC, 10% turnover roughly, it would cost this institution $56 million in cost. And just FYI, I went to a business meeting the other day, and it looks like we're right around 35 million our profit. $56 million, that's a lot of money, okay? So it's like double what our margin is for this last fiscal year. So consequences of burnout, financial, not to mention patient safety. So if you're burned out, you don't pay attention to the chart, you don't pay attention to your chemotherapy orders, right? Patient safety is at risk. Patient satisfaction, you just depersonalize even the patient because of your work conditions, right? So they're not satisfied with you either. And then of course, personal health, right? Leading to depression and God forbid, suicide. So these are major consequences of burnout. So how does burnout manifest itself? So we did a qualitative survey. I don't know if you've ever done this before. We typically don't do this in medicine, but we basically interviewed, so out of 1,145 physicians identified at Keck Medicine. What I did was I just a random generation of numbers, and I basically selected 70 people for a 30 to 45 minute interview. And the first 10 who volunteered for this study, I anonymously interviewed these 10 faculty members. Okay? And so Zoom is great for doing these. I can tell you that I didn't do the interview. Somebody from Oregon that I hired did the interview, and we did it on Zoom. What was beautiful about Zoom is you get a transcript. They basically cut and paste the transcript into a Word document, redact the document for any identifying information, and send it to me. And I basically looked at it, those narratives, and came up with 3 things. So in answer to the question, how does burnout manifest itself, or what does burnout mean to you? Well, for some of them, they said, aberrant behavior. Others said a lack of energy or reserve. Others said a lack of effectiveness or feeling devalued. So you can see that really corresponds nicely to the Maslach burnout inventory, right? So aberrant behavior, depersonalization, a lack of energy or reserve, emotional exhaustion, and lack of effectiveness or feeling devalued, lack of accomplishment, right? So all 3 categories are represented. So the bottom line is our faculty is no different than, no appreciable difference in terms of burnout relative to the rest of the country, rest of the nation. Okay, then we asked the question, what factors contribute to burnout? And the themes were just basically extra work that was not expected, EMR, patient calls, all this stuff, without any meaning, basically activity that you have to do extra that lacks meaning, appreciation, or compensation. So we all know what that is, right? And then the other category was workload that you expect to do, but didn't have the resources to do that, right? But I think the most important thing, and this was done between, the survey was done between April and May of 2021, right at the height of the second surge of COVID. Nobody said COVID-19 was a factor. Nobody, none of the 10 said COVID-19 was a factor. In fact, some of them thought that COVID actually improved their burnout. So I'll just read this quotation to you. At the height of COVID, we were at our tightest. And the funny part is that because of at the height of COVID, we only had one job, and that was to take care of patients. Everything else fell away. And now that COVID has receded, normality established, all the problems are now coming back out. I mean, that is what our faculty think. So this sort of adds meaning and maybe some meat and sinew to the meaning of burnout for us. Okay. So in conclusion, the meaning of burnout is similar to national descriptions and aligns with the NASDAQ burnout inventory. Factors related to extra work that lacks meaning or recognition or compensation, and also expected work that lacks resources. Those are the two main factors that contribute to burnout. And the sources, they said, were the administration, the university, and just the culture of medicine. So those are the sources that are factors that were contributing to those factors. Okay. All right. So that's burnout. We've talked about burnout a lot. Now you understand the definition, how it manifests, and especially how it manifests here at USC. So what do we do about it, right? I mean, is it enough to just say, oh, we're all burned out? No, no. There's been a lot of study on interventions for burnout, and they're broken down into basically two types: individual focused interventions or organizational interventions. The first one we're all very well aware of. There's a lot of wellness courses, mindfulness courses, all designed to improve your resiliency to the environment. So those are individual-based. Organizational-based targeted interventions include basically working on the environment, trying to improve the environment for this Lamborghini to go down. Because if you fix the individual, they still have this environment to deal with. They're just going to break down again, right? So these organizational-based approaches include work delivery processes, getting more resources, systems, and a culture of the organization, right? But who has the biggest impact on the environment? It's the leaders. Leaders have the biggest impact. And when I say leadership, I mean not just the formal leaders of this institution, but also the informal leaders as well. All of us, we can lead, okay? So I want to make that distinction. So when I start saying leaders and followers, please don't take that offensively. What I'm saying is that's just more for clarification of leadership with leaders and followers relationship. But basically, all of us can lead. All right. So just keep that in mind. Okay. So before I talk about leadership, let's just start with a definition. So Northouse is the sort of the Bible of leadership, if you will, and basically they define leadership is a process whereby an individual influences a group of individuals to achieve a common goal. Basic, simple definition. However, I will tell you, the process and behaviors and that interaction between leaders and followers, very complex, very complex. And that is the source of a lot of all those thousands of leadership books that you see on the shelves in your bookstores. The process, and it is a process, and the relationship between the leaders and those being led. So fortunately, those 1,000 books and models and theories on the shelves, they are pretty much converge. All the ideas and the theories behind leadership and followership pretty much converge on very common topics. What I try to do is focus just on behaviors. Rather than look at traits, I try to focus on behaviors of leaders that relate to burnout or relate to performance. And so you may have heard of situational leadership, right? Servant leadership, pinnacle leadership, and also transformation leadership. So all of those pretty much converge on similar things, all right? And so the one that I decided to choose for my model in my dissertation was transformational leadership. Because the transformational leadership model has been around for a long, long time. It's called the full range of leadership model as well. It's been around since the 70s. It's been validated and reliable, so we can actually measure leadership behaviors at our institution. Okay. I'm not going to get too deeply into the transformational leadership model, but just suffice to say, there's differences between transactional leadership behaviors and transformational leadership behaviors. And if you look at this scale of the full range of leadership model, you can see that, you can see that there are transactional leadership behaviors, contingent reward, and management by exception. And then there's less desired leadership behaviors, such as reactive leadership, or what we call laissez-faire leadership. The leader never shows up, okay? Stuff like that. That's laissez-faire leadership. NBEP is basically that leadership behavior. Is those leadership behaviors in which your leaders just react to crises, right? That's considered not a great leadership behavior. And then there's the one that we're all familiar with, is that's the sort of that, not so much the micromanager, but you sit down with your faculty member, let's say your leader or your fellow, and you're basically going over their review, the expected activities, the expected performance of those people. And so you say, okay, well, you know, you saw 3,500 RVUs last year. You did 2 lectures, for example, and you also did, you published 2 papers. So you met the goals. And that's it. So that's management by exception active. And the contingent reward is also a transactional leadership behavior. So now you're sitting down with them and saying, okay, you give me 10% more RVUs, I'll give you 10% more pay. So a transaction. So these are transactional leadership behaviors, and they basically are people that respond to external stimulation. Now, what you want to do is you want to be able to get folks to be autonomously motivated. We call that the 4 I's. Okay? Idealized influence, inspirational motivation, intellectual stimulation, and individualized considerations. I'll talk about that in a second. But basically, just know this. There's a scale. Bad leadership behaviors, better leadership behaviors. Externally motivated, autonomously motivated. So that's the main difference. Let's see if this works. Okay. So transactional leadership behaviors. Any questions on that? So basically, you scratch my bag and I scratch yours. There's 2 cats exchanging external or transactional behaviors. Okay. So is that clear? So let me ask you this, just a raise of hands. Is transactional leadership behaviors bad? Anybody think it's bad? Anybody else think it's good? Okay, so no one's answering. But I will say this. Most of the literature that we read in the physician leadership literature is all about transformational leadership. Right? And no one ever looks at the transactional leadership behaviors. And guess what? Transactional leadership behaviors are actually good. It's kind of what we do, right? We need performance reviews. We need accountability, right? Accountability is the basis of leadership and followership. So this is a great picture. One of our business school students, or business school faculty, gave this talk. And I'm assuming you probably remember this talk. So Glenn Fox from the business school came over and gave a really nice talk. And he basically he did a study looking at gratitude and accountability. You can see that there's 4 quadrants. There is high gratitude, high accountability, low gratitude, high accountability, no accountability in this column, but high gratitude, and low gratitude and low accountability. So he was describing how he did this. He basically got a bunch of leaders that demonstrated these 4 different types of transactional leadership behaviors, and they measured performance. And of course, what they found was high gratitude, high accountability had the greatest performance or the highest performance. This was a distant second, but no accountability was way distant third. So accountability is important. Transactions are important. Performance is based upon some of these accountability measures, okay? So that measured by exception after transactional leadership reviews are not necessarily bad. Glenn Fox went ahead and categorized this as contingent reward. He called this managed by exception active or micromanagers. And he called this, I love this one, high gratitude, low accountability, empty calories, that donut we just did, right? And finally, low gratitude, low accountability, passive. So you can see that transactional leadership behaviors can be good. I just want to point out accountability is important. Okay, so accountability. What is accountability? Accountability is nothing more simply a contract between a director and a provider, between a leader and a follower, those being led, right? So it's a contract. And I want to point this out. It's a reciprocal contract. So, for example, a director and a provider provides services, right? So we're seeing patients, we're making the widgets, right? Well, we expect our leaders to provide the resources, the encouragement, and the environment for us to function well, right? So this is a reciprocal accountability. It's not just accountability down. It's reciprocal. I think that's very important to know. When I first took command of my first combat support hospital, I was just a doctor. I didn't know what to do, right? So, they just made me commander. And I took over this 800-man combat support hospital. And one of the things that they said was, take care of your soldiers. That's the only thing I want you to do. Take care of your soldiers. I didn't exactly didn't really know what that meant. But what that meant to my staff that they gave me four categories of staff members. They said, sir, you just have to provide them with resources. You got to get the food and fuel and stuff to them so that they can do their job. That's all you need to do. And you got to encourage them. You got to create that environment. I said, gotcha. Okay. So I was responsible as the leader, okay, to help them perform. All right. Okay, so I already asked this question. We went a little out of order. Best 3-minute video on leadership I've ever seen. For those of you that don't recognize, how many people recognize it? Okay, well, you young guys. This is Colin Powell. Good job. What was that? This is Colin Powell. Colin Powell was a Secretary of State. It was his last job. And he was answering the press about what leadership is. So I want you to take away and look at this and see what you think and look at what he says. And I'm going to have to come over here and take some notes because it says.
My question is, how do you find key characteristics of executive that allow you to go and get after this?
The longer I have been in public service, the more people have leadership ultimately comes down to creating conditions of trust within an organization. Good leaders are people who are trusted by all. Leaders take organizations past the level that the science of management is. One of my sergeants back in the infantry school at Fort Benning 50 years ago, before I learned everything about leadership, was at the infantry school. And he said to me one day, Lieutenant, you'll know you're a good leader when people follow you only out of curiosity. I've never had a better definition. Because what he was saying, and I've seen it experience in my life sometimes. What he was saying is trust you. And we develop that trust. How did you do it? For a mission statement, self-service. People look to you and they trust you because you're serving selflessly as the leader, not self-serving, selflessly. And that you prepare them for all of this. You train them. Give them what they need to get the job done. Don't give them a job if you're not going to give them resources. And then you're prepared to take the risks with them. So they were teachers, no matter how cold it is, Lieutenant, you must never look cold. No matter how hungry you all are, Lieutenant, you must never appear. No matter how terrified you are, Lieutenant, you must never look terrified. Because if you are scared, terrified, hungry, and cold, they will be scared, terrified, hungry, and cold. I've gotten away with that many times in the course of my career. I've been scared to death, cold, and wanting to go to sleep. But now, let's keep going. Let's go around this corner. They'll follow you in the dark at night. This valley of the highest. The essence of leadership is that in all of the science of management, take that extra step to make that spark. Spark comes to
What'd you think? So what were some of the take-home points that Colin Powell made? Anybody? So beyond what the science and management says you can do with resources, what are some of those leadership behaviors that can build trust? Right? What are they? So he said, clear mission statement, right? Clear mission. So you gotta communicate, you gotta talk the talk, right? I just call it talking the talk. You gotta model what you say. So taking a risk with your people. You don't want them to, you want them to suck it up and move on, right? And so he goes in there and says, well, if you don't want to look scared in front of the troops, right? So he's modeling behavior that he wants them to do. In our situation, I know I was a fellowship director. I wanted them to see patients and not complain. I would just grab those charts when it was overtime. They had to go to a lecture. I'd grab a couple of charts and see myself. Or they're counting. Right. So modeling behavior. And also, what's the other one? Any other transformational leadership you can see? Selfless. So those are values, right? Those are values. So if you're doing this selflessly, if you're doing this for the people, for the people you're leading, then they get that. And you're taking risk with them, right? Taking a risk with your people, getting that chart, right? Taking risk. That builds trust. And then the last thing I talked about was making sure you can train your people. Train them, watch them grow, watch them develop, train them so they can, that's what we call individualized consideration in the forms of leadership model. So those are the 4 I's. He basically encompassed this within his 3-minute video. Amazing. He probably didn't even know it. So really quite a 3-minute video. I would look at it again just for inspiration. Okay, the 4 I's, idealized influence. So idealized influence is nothing more than modeling the behavior, modeling the values that you say you're going to model or that you talk about. Right? So that's walking the walk. This is inspirational motivation. All right, and if you haven't seen this old video, this is a football coach in the locker room, and a kudos if someone can identify who this coach is. Oh shoot.
I don't forget, man. Today, we're gonna win. They can't take it. Get out of the ball. We're going to fight. What do you say, man?
Nassim, who is that? She doesn't watch football. Newt Rockney, Notre Dame football coach, right? And wait, that's true. You're right, USC. So yeah, inspirational motivation, right? Talking the talk, firing people up, right? Okay. Intellectual stimulation. So this is about innovation, right? We're facing a crisis right now. We're facing a turnover issue here at USC. Well, it'd be really nice to know what everybody else thinks because no one person can possibly know every angle And it's not just compensation. It's a very complex situation why people are leaving. So it's not just resources. And finally, individualized consideration, basically watching for the growth and development of your people. So that's, what was really interesting is there's no, we keep talking about professional development. So we started to develop, we developed this course for that purpose, to develop people and for people to grow. And so the last I is individualized consideration. And this is Confucius, of course. And so he's watching out for the welfare of his people in terms of growth and learning. Okay, let's see. So that's a theoretical model. How about the physician literature? So I basically, oh shoot, one second. What are the expectations? If I do this, okay. What are the expectations of physician leaders when you glean the literature, right? So one area is expertise. You have to be an expert in something, right? So you have to be clinical, educational, research. You should be an expert in something. So the implication is that you're still practicing, right? Practicing, or at least, an expert in the area. The second thing that they talk about is relationships, right? So relationships, support, relationship behaviors, support, consulting, recognizing, empowering your subordinates, and developing. Those are the relationship type behaviors that are expected from the literature of physicians. Task accomplishment. The task accomplishment is nothing more than short-term planning and accountability, right? Tasks. Short-term planning, monitoring, and clarifying roles. Those are the activities of a leader, right? So basically, task-related activities. And finally, and the hardest one is change. So in an environment like this one, we have to be thinking about change, right? Change. And so in the full-range leadership model, that's about innovation and engagement of people, right? So in the military, we love acronyms, right? So I just came up with that. So PACCOM, Pacific Command, basically that is the tasks. So planning, short-term planning, clarifying roles, monitoring, accountability, relationships, support, consulting, recognizing, empowering, and developing. And every time, right? That comes forward every time. So the change behaviors that people identified for change behaviors is looking at the external environment, reading the external environment so that you can adapt your organization. V is developing a vision that sort of falls into that adaptation. And R is taking risk. So change is risky, right? And finally, innovation. Innovation is key. And then from this time, you can start seeing improvements in your organization. So I use that mnemonic for my checklist of things I need to do as a leader. Okay, so let's look at some data. This is some quantitative data from my survey. Right? And basically, again, this is during COVID. There's 1,500 faculty members at USC Medicine. I excluded the pediatric department because they mostly practice over there at Children's Hospital. So that left 1,145 faculty members. I sent out surveys that combined the full range of leadership model with the NASDAQ burnout inventory. And what we found was 305 surveys were returned. What we found was that the burnout rate at this institution was 53%. Back then, 45% was the number, the national average. And Cleveland Clinic's at that time was 35%. 35%. So that gives this number some meaning. Yeah, there's some local stuff going on here. That's a little different about us, right? And what I found was also, I tried to correlate leadership behaviors with burnout. And you can see that these are two transformational leadership behaviors. Note, I didn't look at inspirational motivation or intellectual stimulation because I had to shorten the survey somehow. You know, doctors hate filling out surveys. So basically what I looked at was individualized consideration. You can see that the more individualized consideration that a leader demonstrated, the lower the burnout. Those leaders that modeled their values, you can see that there was lower burnout as well. So those are two good leadership behaviors. This is contingent reward, one of our transactional leadership behaviors. Guess what? There was a correlation with lower burnout, and those that demonstrate contingent reward. And then management by exception active, pretty much is a flat line, so no correlation at all. And then you can see that laissez-faire leadership, and reactive leadership show increasing burnout. So I can say this, at USC, these type of leadership behaviors matter, okay, in a good way, as far as burnout goes. Any questions on that? And these are statistically significant. This is just looking at depersonalization, just one component of the NASDAQ burnout inventory, but it was universal for emotional exhaustion as well as lack of accomplishment.
Did you see that information from the participants about their leaders?
Yes, yes. So that part wasn't anonymized. Well, I didn't know who they were. It was just a number. So yeah, I looked at 4 demographics. I looked at, let's see, age, sex, let's see, department, or not department, surgery versus ancillary versus medicine. I can't remember what it was, but there were 4 demographic factors. Yes.
So when you're talking about leadership surveys, are you talking, is there a clear definition of whether you're talking about based on leadership versus health system leadership versus county leadership?
Absolutely. So that came up on our score survey because we didn't know who we were rating, right? This was physician leadership. Specifically said you're a physician leader, right? Your immediate physician leader. And so that's where we're rated. So this is a true, as good an accurate test of physician leadership as we can get. Measurement, yes.
Finding trends?
Yeah. Well, I'll say this. I think surgery was slightly better in terms of the good leadership behaviors, and maybe medicine. At least their people perceive them as being better leadership behaviors. Okay. Let me move on here. I got one more graph I want to show you. So, how does physician leadership compare here at USC? Right, compare to national averages. So here is a graph. So here's all the different leadership behaviors, from bad leadership behaviors to good leadership behaviors. And these are the norms, right? This is occupational therapy from Australia. This is other healthcare organizations, Kaiser and other corporate healthcare organizations. You can see that our mean score in these good leadership behaviors is lower than the norms. Right? And similarly, the bad leadership behaviors are a little bit higher than the norms. Right? So we've got some work to do. And this is the real killer for me. Individualized consideration. Right? We're an academic medical center. We train fellows and residents. But for some reason, Kaiser does a better job of treating their faculty with individualized consideration than we do. Right? So that's what really is amazing to me. And so these are all surprising findings. I have not published this, but this is what we found. Okay. I'm not going to get too much in. This was part of the qualitative survey. But when we asked them, if you had 5 minutes to advise your leaders on burnout, what would you say? To add a little bit more meat to this study. Look at this. Feeling heard was a big one. Right? So our faculty are not feeling heard by their leaders. Okay, so I'm not going to go there. Let's see if this works. Can you advance that, you think? Oh, that's right. Do this. Okay, so what does this all mean? And I wanted to leave you with maybe a practice, a best practice that we can implement immediately. All right. So I'm not going to talk about styles. We all know there's different styles. There's the commanding style, and then there's that more like development style of John Wooden, right? These are basketball players, by the way, basketball coaches. So leadership style. So this was a slide I stole from James Starr, the father of physician leadership. He gave a grand rounds on last Friday. It was amazing. But he says we are challenged to be democratic leaders and authoritative leaders because we basically have been that person who commands, basically the OR, commands the team on the wards, right? So we've been brought up that way, right? It's more challenging for us to be democratic and to be distributed in our leadership style. So you can see there's commanding and then there's pace setting, but these are the leadership behaviors that we're starting to move towards, that something called distributed leadership. For distributed leadership, you can read that, but basically what it is it's engaging your faculty if you're a leader. It's engaging your followers in the decision-making process without relinquishing accountability. It's involving people in the decision-making process, right? Feeling heard, right? And here's a paper that shows that those folks that have distributed leadership agency, or those leaders those people that perceive distributed leadership as being practiced, you can see that innovation, that thing for change, that behavior, leadership model behavior that needs to change goes up. And that's a pretty strong correlation. Lower correlations were occupational self-efficacy. So basically, the faculty felt a little bit more self-efficacious and job satisfaction. Okay, implementation. I'm going to give you a case here. And this actually happened. 40-year-old assistant professor is quoted by adjacent City Hall. Okay, your discussion with this member confirms this, and you ask, why are they leaving? They tell you that they're working hard. There's nowhere to promote to, and the administration messed up my packet for promotion to associate professor. So, and yours truly talked to the leaders. Hey, you might lose this person. What was your strategy? Let's wait till City of Hope makes an offer, and then we'll count it. Massive fail. She's gone. So, me being the self-reflective leader, I'd say to myself, what the heck just happened? So I'd say to myself, okay, next time this happens, I'm going to address recognition by giving her maybe a title and a position. I'm going to investigate and advocate for speeding up promotions. So I got to go to the dean or the faculty affairs office and say, you got to speed this up, guys. Send a leadership course to groom for director position. Address meaningful activities. Maybe give her some resources like an APP. And finally, maybe some compensation as well. This is all to say, hey, look, this is a very complex issue in people. It's not all about compensation. Okay, so now that I've learned this, how do I embed this into the culture? Case 2, real case, all right? So I'm the fellowship director. As the fellowship director, you receive word that your burnout scores were high for the 18 fellows. You have to figure out a strategic plan to deal with these issues. You immediately ask for a meeting with the fellows. In the first meeting, no one spoke up. So then you go over and you talk to your chief fellows and say, hey, how can no one spoke up? Do you have any recommendations for me next time we have a meeting? So why don't we anonymize it? So basically what happened was the 18 fellows wrote the chief fellow a little note about what they wanted to talk about, what the problems were. He presented it to me. Okay, so I made them anonymized and made them feel safer. Okay. The second meeting, we were also able to identify the problem and maybe some solution. And the problem here was accounting. It was just way too many patients. These guys were seeing 18, 20 patients when they're supposed to be seeing 8 at the most. It was ridiculous. And of course, I went over to accounting one day. I said, this can't be. So I went over there. It was 4:30 in the afternoon for the breast clinic on Monday. And they were all still there, and there was a stack of charts left. So what did I do? I walked over to the desk to ask, how did all these patients get in here? There's 130 patients in this clinic. And they said, well, look at the templates. The templates are just open. I go, well, you got to change that. You got to change those templates. He goes, okay, well, you have to go to administration accounting to change those templates. Okay, long story short, we identified this as a problem. Okay, then the third meeting, so we report on the progress, right? Okay, I wrote the templates out, I sent it to their leadership, but we're not quite there yet. Fourth meeting, nothing happened. Now they're getting really discouraged. Fifth meeting, I decided, you know what? I think I'm going to have to do a little bit of leadership and take a little bit of a risk. And if you think of systems, their system is one where it leads to DHS, right? DHS is the Department of Health Services. And I'm going to take a risk. So I'm going to talk to these guys. Guess what? The templates were implemented the next day. Okay? So, what's the lesson here? Accountability. Leadership accountability. Right? I took a risk. And these guys, these guys felt that I was putting it out on the line. Right? Accountability. Reciprocal accountability. Following year, the burnout scores improved by 50%. Now, I don't know if it was all because of that, but I just ended up doing it. So this is something that I would do. And what is that called? It's called the after action review. Get your faculty in a room, anonymize their responses to the problems at this place, come up with some solutions, and innovate. Take risks. Engage them. Okay, so actions now. So the UCL model, I'll just show this. So implementation after action review, it checks all these. So external environment division, the changes in blue, relationships are in red, and you can see that it pretty much hits everything. So if I were to take over some unit, this is the first thing I would do because you're innovating, you're building relationships, you're engaging. And it doesn't help recognize and develop, but I might engage my staff to see how I can get these promotions and courses paid for or done. This is called the after action. I can tell you that this AAR, it works. It works in all of these cultures. So all these cultures are represented here at this institution. All right, this is archetypes of culture. The collegial culture, which is our culture, we deal with each other professionally, right? There's a managerial culture that's focused on efficiency, right, and process. There's a developmental culture, which is developing people and making sure that they grow, right? And then there's the negotiation culture where it's all about interests. So all these AAR lessons, these after action review lessons, can be applied in all these cultures. Running over. So readings, this is a great book by John Carter. So this is, John Carter is this leader of implementation. And he basically talks about 8 steps. But if you read this book is really easy to read. It's almost like a child's book, right? And I was basically watching the World Series or the playoffs. And so by the 4th inning, I finished this book. I gotta put it up. But this, if you can get this book, this might be, so you'll recognize some of the penguins in this book, okay? So this is about leading change. Okay, anybody ever watch Ted Lasso? Okay. So these guys represent, all these coaches on the soccer team represent the coaches on the team. And this person here is the expert. He knows more about soccer than anybody. This person here is all into performance. Coach Beard, he's into performance and task accomplishment. Right? This guy, he's into relationships and change. So this is basically a synopsis. This is my final slide. This is the spectrum of leadership, and these are the behaviors that lead to improvement. Any questions? Covered a lot of ground.
In the data that you collected, do you have enough data to look into the subtypes of the transactional leadership style that you mentioned? Because I was very intrigued when you showed that slide by Glenn, someone where where you said like micromanagement was better than where the empty calories one where it was just like encouragement without accountability. I was very surprised by seeing that slide. I would assume that if somebody trusted me, which is giving me the freedom to do what I do, and I would be more productive than like somebody micromanaging me, which means basically they don't trust my work.
Well, I would just say this, those performance reviews, there's certain ways of doing it, right? I mean, you could just say, okay, you met your performance, bye-bye. Have a good life. Okay. Or you can say, you know, you met your performance. I know that you have a lot of issues at home. I know that you have 2 kids. I know that, you know, you're really, really busy. I know that this environment is not exactly the best, but you met your performance, which is really appreciate it. Expressing that gratitude. So that's what we call contingent reward. So there's a lot of ways that you do transactional leadership. So no, I don't know if they show gratitude or not. I don't know. All I know is that the questions on contingent reward get answered and they correlate. So that's the first time, by the way. It's never been demonstrated in a physician leadership population. It is a physician faculty population. That contingent reward matters. That's what I think the strength of this, and this is published in Military Medicine, 2022. They're really the leadership in the military, right? And so if you want to read it, it's in there. Anything else? Yeah.
As a follow-up to that, or a comment, so is gratitude the main component of that, or is it mostly financial leadership?
Yeah, unfortunately, this study can't really show that. It didn't really show, wasn't detailed enough to show that. But it could be any of those categories. It could be compensation, it could be recognition, it could be any of those. When people have applied this full range of leadership model to other industries like business or the military, right? What they found was that in those populations, contingent reward and individualized consideration actually segregated out together. And the explanation for that is that if you give enough contingent reward over time, trust develops, right? Because you're honoring what you said you're going to honor. Right? So contingent reward is pretty powerful still, even in our population, a bunch of autonomously motivated people, right? So even contingent reward is important. Okay, all right. Oh, another one.
So, in terms like this approach what? So I know you tailored it to USC, but are there more efficient leadership setups out there? Because I think my frustration is I think one of our problems here at USC is the multiple hierarchies that all have their own different, and it's not all coherent.
Super question. So Dr. Johnson here has to answer the 2 lines of authority, pretty much, right? Even though the formal line of authority is with the dean, right? In reality, there's a business side as well. So you've got 2 lines of accountability that you have to report to, right? Yes. In our course, Nassim is smiling because we looked at systems, right? So we looked at systems. And one of the things that we found, and there's a bunch of slides at the end. I don't want to talk about systems too much. But if you look at the way USC is organized, there is no system, what we call systems 3. There's no system that unifies both the development side or the development culture with the efficiency or managerial culture. And in fact, I would say that the managerial culture doesn't even interact with us hardly at all. So you're right, it's an organizational problem as well. So we talk about, when we talk about leadership, we talk about knowledge, motivation, or organizational structure, right? And so I think in our situation, it could very well be organizational structure because we have a very divergent organizational structure. Right? So yeah, it's complicated. Now, as part of our course, our our participants in the leadership course, they meet with the business side. And one of the things that that one of our CEOs brought up was that, well, we're trying to integrate it. We're trying to integrate these silos, right? So it could be Department of Medicine and Surgery, right? It could be those. We're trying to integrate these silos into an institute model. And we've already seen that with GI. So there's a GI institute, and we've already announced that Dr. Buxbaum is going to lead that institute. So, and that's a multidisciplinary institute. So that's the start to improve sort of the inter-silo communication and resource sharing. So anyway, that's you're right. It's a systems issue as well. Sir.
I have a quick question for you. So this is about the contingent reward. Is there an effective, or have you found an effective strategy to discovering and offering contingent reward during like resource starvation? For example, I think when there are not great rewards available, because offering rewards that not come through is in fact a betrayal of trust, I think many would resist offering what they can't come through. So how do you build trust?
Well, if you're resource restricted, there's nothing preventing you from. I just had this conversation with one of the other chairs, and they were resource restricted. And we had somebody that was like that first case. She was ready. She was ready to leave. What did they do? Well, they recognized them. Gave them a title. They gave them all those other parts besides just straight compensation, because it's all of those. It's a very complex web. So I guess what I would say is I would recognize them. I would make sure that they're doing something meaningful. If you can't get resources like with compensation, you might be able to look at your organization or another organization and say, okay, I think you need an APP. Can I borrow a 0.2 FTE in an APP to help this person out? So there's a lot of, and we call that agency, right? That was one of the, I didn't go over this. Yeah, okay, look at here. Agency. One of the things in the qualitative study that we found was that they would say things in response to the question, what has leadership done to address burnout? They would say, well, nothing. There's nothing they can do, right? And we call that a category of no agency. I'm writing a paper on agency right now. So there's a lot of things you can do short of giving them that huge bonus that Cedar Sinai gives you, right? There's a lot of things you can do. So, and most people that come here, I took $100,000 pay cut to come here from the Navy Medical Center in San Diego, where I was a contractor. That's because it wasn't all about compensation for me. It was about doing something meaningful, being recognized for it. So I think all of us are in the same boat. We don't go to an academic medical center and make money, right? So it's not all about compensation. I'll just say that. And get together with people here, engage with your faculty. Right? Do you have AAR? Your problem, and talk about these things in a very safe environment. Right? And so I think that's the key. That's where you come up with these innovations. Agency. We all got agency. I don't want to get into agency. You ask the question. Okay, well, thank you all very much. If there's no other questions, I got to get back to my clinic. I am a frontline physician, so thank you very much.